And now we can move to Dr. Lilly's lecture, the cardiovascular disease impact on sonography's findings. Dr. Lilly, welcome.
Thank you. It's wonderful to be part of this program. Well, I would like to again welcome everyone and appreciate your interest in these topics. I think Leandro has laid out some of the basics of diagnostic use of carotid duplex scanning. My talk is more of a, I guess we'd say, show and tell of some features of carotid duplex that may not be things that we commonly think about in the diagnostic laboratory. So my focus is on the impact of cardiac disease on carotid velocity spectra and waveforms. I have no disclosures relevant to the topics within this talk. To begin with, I think we should consider what it is that is the general flow pattern that we see in peripheral arteries. And it's important to remember that peripheral arteries are relatively low volume and relatively inelastic blood vessels. Remember, only about 12% of the blood volume resides in arteries at any given time. And that unlike veins, which are very compliant, arteries are relatively inelastic, with the exception of the thoracic aorta, which has a substantial elastin component, and its viscoelastic properties are actually very important in some of the things that we'll discuss in a few minutes. Flow characteristics in peripheral arteries, generally high velocity and high flow. These flow characteristics are determined by a number of features, many of which relate to the heart. So cardiac ejection is obviously the main motivating factor. Remember, with each heartbeat, the normal heart will eject approximately 60 to 70% of the volume of blood within the left ventricle. And that results in a stroke volume of about 60 to 70 milliliters with each heartbeat. The function of the aortic valve is critically important, and I'll show you that in some of the things we discuss going forward, as are the viscoelastic properties of the aorta, again, principally talking about the thoracic aorta. When we look at peripheral arteries, the influence of peripheral vascular resistance is very important, and this diagram here is just a typical simple Doppler waveform or of a peripheral artery, in this case the posterior tibial artery, showing a normal high resistance peripheral arterial flow characteristic. Now, for those of us who work primarily with the pipes, that would be the arteries and veins, it's useful to look at the heart every now and then. And so this is what the heart looks like. And the illustration here shows the aortic valve in both open and closed conditions. The valve typically has 3 leaflets, and when open, the orifice is nearly the full diameter of the aortic outflow. The ejection passes from the ventricle into the aortic root. When the aortic valve closes, the elasticity of the aorta propels the blood into the peripheral arteries during diastole. This diastolic flow is most commonly seen in arteries that have low resistance flow characteristics, and those arteries are typically the carotid and vertebral arteries. So there's a few basic things to keep in mind when we talk about the effects of cardiac disease on what we see in the peripheral arteries, and in particular in the carotid arteries. And these are extremely basic, but you have to keep them in mind. Remember, the heart is proximal to all of the arteries in the body. So any changes in flow that are generated by a problem with the heart will be demonstrated in all of the arteries in more or less a uniform way. The impact of the cardiac diseases, however, is most pronounced in the arteries that are closest to the heart. And this naturally makes sense. Recall that the carotid and vertebral arteries are approximately 15 to 20 centimeters from the aortic valve, and so it's likely that the diseases of the heart will produce significant identifiable changes in these blood vessels. The key to identifying the cardiac etiology for flow pattern changes or abnormalities that we see is symmetry. And that keeps in mind the idea that changes in the heart will affect flow in all of the arteries. We'll be hitting this symmetry point over and over again as I show you some examples. So these are some of the pathologies that I would like to go through with you today. And again, I'm going to show you some examples and give you some pointers on how to identify and consider some of these pathologies that you may encounter. I'm not going to present a lot of didactic or scientific information. So the first condition to consider is aortic stenosis, and there's a variable etiologies for this problem. In some cases, it's congenital. Rheumatic disease is, prevalent in some areas of the world, less so in others, and will present with aortic stenosis at different ages. The bicuspid valve, which is an anatomic anomaly, usually presents with stenosis in the 50s and 60s, and degenerative disease, often calcification of aortic valves, happens in older folks. The impact is a flow-limiting stenosis proximal to all the arteries in the body, producing symmetric alterations in flow patterns. So I have two illustrations here. The upper panel shows a patient with significant aortic valvular stenosis. The lower panel is a normal individual. And these are both taken from the right common carotid artery. And what you notice in the patient with aortic valvular stenosis is a prolonged acceleration time and a delay to reach the peak systolic velocity in comparison to what we see in the normal. Very brisk upstroke here, very delayed upstroke in the patient with valvular stenosis. This pattern will be seen in all of the arteries affecting the upper body. You'll see this in both carotids and both vertebrals. Now, we're used to seeing this kind of a pattern in peripheral arteries distal to a stenosis, and we see it so frequently that there's a term that we use to describe it. It's often called tardus parvus. Tardus meaning late arrival of the pulse or a prolonged acceleration phase, and parvus meaning that the flow is relatively low. With aortic valvular stenosis, we see the tardus component, the delayed upstroke or the prolonged acceleration time, but generally the flow velocities are fairly well preserved. So here's a patient with severe aortic valvular stenosis, and I have images from the right internal carotid, this panel on the left side of your screen, the left internal carotid, the panel on the right side of your screen, and then the right vertebral on the bottom. We don't have a left vertebral image here because this patient's left vertebral artery was occluded. But what you can see is asymmetric, uniform delay in the acceleration time in all three of these vessels that supply the brain. So the symmetry component very clearly demonstrated here. So you can be fooled by your suspicion for aortic stenosis, and I'll give you an example of that. So here's a patient with this is an examination of the right proximal common carotid artery, and you can see that this spectral velocity display shows a prolonged acceleration time, certainly something that we would make us very suspicious. This patient may have aortic valvular stenosis. Well, what about symmetry? If we look at the left common carotid artery in this patient, we see that there's a very rapid upstroke here, a very normal kind of characteristic, although the peak velocity is relatively high at 190. This is a display of the images from this patient, and again, it's displayed pretty much the way I've shown you before. On the left, we have the left side of your screen, we have the right proximal common carotid artery. On the right side of your screen, the proximal left common carotid artery, and then the right and left vertebral arteries. And you can immediately see that we see this prolonged acceleration time in the right proximal common carotid artery with normal brisk upstrokes in the left proximal common carotid and in the left vertebral artery with a more or less bizarre vertebral pattern. And this is the pattern that we see in a patient with a right brachiocephalic artery stenosis. So here we have a central intrathoracic stenosis that affects only the blood vessels on the right side. This is not a cardiac lesion, it's a brachiocephalic artery lesion. The next area I would like to talk about is aortic insufficiency. And again, there's a number of different conditions that result in aortic insufficiency or aortic regurgitation. Many of them are the same conditions that produce aortic stenosis. They just have a different manifestation in different individuals. Diseases of the aortic root, cystic medial necrosis, Marfan's, and so on. We see endocarditis frequently destroying the valve leaflets of the aortic valve, producing aortic insufficiency, dissections, and some other conditions. When we think about aortic regurgitation or aortic insufficiency, it's important to think about what is the force that drives forward flow during diastole in the low resistance arteries of the body, like the carotid and the vertebral arteries. Well, the force propelling the blood forward is elastic recoil in the elastic segments of the aorta, which is the thoracic aorta, primarily the ascending and arch segments, with less elastic component in the descending thoracic aorta. So in this diagram here, during systole, the ejection of blood from the ventricle produces this increase in flow. With systole, when the aortic valve closes at the second mark here, this additional forward flow during diastole is propelled by the elastic recoil of the aorta, and then the second cycle thereafter. So in aortic insufficiency, what we lose is the diastolic forward flow component. And well, this is not because the aorta has lost its ability to have elastic recoil. It's because there's another place for that stroke volume that was held in the aorta to go other than the peripheral arteries. And the place it goes is back into the ventricle through the incompetent aortic valve. So what we typically see in aortic insufficiency is a loss of diastolic forward flow. And in fact, in many cases, particularly if you're close to the heart, like the common carotid arteries, reversal of flow in diastole. And this is two different patients here with different heart rates, showing that absence of forward flow during diastole, and in fact, in both of these cases, reversal of flow, more pronounced in the upper panel than in the lower. And generally, we refer to this as holodiastolic flow reversal. Here's another example showing the same thing in a left common carotid artery of another patient. Symmetry remains an important component. So here is a panel of samples taken. Again, the display is similar to what I've shown in previous slides. The left upper panel on your screen is the right common carotid artery. The left upper panel, or excuse me, the panel on the right of your screen is the left common carotid artery, and then the two vertebral arteries are below. And you can see that in each of these blood vessels, there is absence of diastolic forward flow. And in fact, if you look at the left common carotid artery, and somewhat less pronounced in the right, diastolic reversal of flow. So there's a symmetric change in flow patterns in these arteries. Well, just like with aortic stenosis, you need to look for symmetry. And if you're very focused on some of these things, you might make a mistake in considering a cardiac cause for something that may be a peripheral cause. So here's a patient with a left vertebral artery that shows holodiastolic flow reversal. This patient also has a little other problem we won't go into, but holodiastolic reversal of flow, certainly suggestive of aortic insufficiency. However, the cause in this patient was not that. If you look at the contralateral vertebral artery shown in the upper panel on the left side of your screen, the right vertebral artery has a very normal flow characteristic with a brisk upstroke and forward flow through the entire cycle. In fact, that same pattern was seen in the left and right common carotid arteries. So this is the flow pattern we see in an isolated left subclavian stenosis, and this is bidirectional flow in the left vertebral artery. This is something that many of us have seen in clinical practice. Here's another couple of cases where we see the pattern that we've talked about, absence of forward flow during diastole, and in fact, reversal of flow. These are two different patients, both of whom show flow characteristics in these right common carotid arteries, like we would expect in a patient with aortic insufficiency. And you'll have to take my word for it, but they had the same flow patterns in the contralateral common carotid and both vertebral arteries. However, these patients had different conditions. In both cases, these were diseases of the aorta. And so what may be happening here? Instead of the flow of the ejection or the stroke volume that's ejected by the ventricle going back into the left ventricle in the situation of aortic valvular insufficiency, in these cases, the patient had a large thoracic aortic aneurysm that accommodated that stroke volume and did not have elastic recoil. And in the case of the dissection, the patient had an alternative place for that stroke volume to go, the false lumen of the type B dissection. So aortic pathology may give you a picture very similar to what you might see with aortic valvular insufficiency. Here's another trick for you, and I don't think you'll fall for this one, but in any event, here's a right common carotid artery image in a patient, and I'll show you other images in a minute, but this has a very finding similar to what we were talking about, absent diastolic forward flow in the right common carotid artery, suspicious for aortic valvular insufficiency. Well, if we look at other arteries on the right side, we can see what the actual cause is in this case. This panel on the left upper side of your screen is the one I showed you a minute ago with the proximal common carotid artery showing no diastolic forward flow. The next panel down here in the middle is the right distal internal carotid artery, and this also has no diastolic forward flow and a very clipped, sometimes we refer to this as staccato, pre-occlusive kind of flow pattern. And if we look at flow in the right vertebral artery, or over here on the right side of your screen, the left internal carotid artery, you can see that those flow patterns are normal. So this is the typical picture we see in someone with an intracranial high-grade internal carotid artery stenosis. We don't see the stenosis in the neck, but we see the impact of that stenosis in the right common carotid artery and in the right internal carotid artery. So again, you're probably tired of hearing this, but the symmetry is the key to this. Another finding that you may see in some of these cases is an unusual one. It's called the Bispherians pulse, and that refers to a duplication of the pulse. This is often seen in severe aortic valvular insufficiency, sometimes combined with aortic stenosis. In other words, combined stenosis and insufficiency. And you get a characteristic double pulse with each cardiac cycle. So this little triangle here points to the typical dicrotic notch that we see in the deceleration phase of most carotid waveforms. The big arrow is pointing to the this decrease in flow velocity in the middle of the cardiac systolic phase. This is referred to as mid-systolic retraction. The actual physiological cause of this is not really well elucidated, and there's not a lot of agreement about what may cause it. This abnormality may be seen in other conditions: hypertrophic obstructive cardiomyopathy, a patent ductus, arteriovenous fistulas, or in some hyperdynamic patients. But this is an unusual characteristic that points to that kind of problem. And again, symmetry. You would expect to see this in all of the vessels going to the cerebrovasculature. So another condition we should talk about is left heart failure. This is commonly due to either coronary heart disease or valvular heart disease. Could also be due to cardiomyopathies, infectious or of other etiologies. And there are some drugs and toxins that may produce that heart failure as well. One of the characteristic findings we see in left heart failure is pulsus alternans, and the pulsus alternans is the result of variable ejection in a ventricle that's really struggling. In these patients, the heart rhythm is regular, but the ejection varies. This particular patient, the ejection seems to vary on a regular basis. Sometimes it may be a little different than this. Clinicians can sometimes identify this if they have very sensitive fingertips and can feel the variation in the peripheral pulse with the different heartbeats despite a regular rhythm. Generally, this pattern of flow has a very poor prognosis. With people who have severe heart failure, you can see this kind of a pattern, and this is an individual with a particularly bad heart. The ejection fraction was estimated at 10%, and he was undergoing an evaluation for placement of a left ventricular assist device. And here you can see the right internal carotid artery. On the right side of your screen, we have the left internal carotid and then the two vertebrals below. What you see is there is an arrhythmia. You see a systolic upstroke that is relatively delayed and generally low peak velocities in all of the vessels. So this is a situation where we see the tardus parvus waveform throughout the carotid and vertebral arteries. This is not due to a stenosis. This is due to pump failure. So that's a little bit different picture than you might see. Intra-aortic balloon pump produces some interesting flow changes in the carotid arteries. The intra-aortic balloon counter pulsation has sort of come in and out of practice over the years. I think it's kind of on its way back in some settings today. It's generally used for low output heart failure in individuals who may be having a coronary revascularization or maybe need a new heart. The pump is inserted through the femoral artery. The balloon is positioned in the descending thoracic aorta, and the cycles of inflation and deflation are synchronized to the cardiac cycle with the EKG. The balloon inflates during diastole at the closure of the aortic valve, and the idea is to increase pressure in the aortic root and increase coronary perfusion, which occurs during diastole. The balloon deflates at early systole at the opening of the aortic valve to produce a potential space in the aorta for ejection, thereby reducing afterload and heart work. The balloon can be set at a 1-to-1 ratio or less frequently. And so in this slide, I have a cartoon showing you the placement of the intra-aortic balloon pump in the descending thoracic aorta, and then a tracing, and this is the right common carotid artery of the cardiac cycle with balloon usage. So if you start at the leftmost side of this tracing, this is the normal ejection of the ventricle. At this point here, the aortic valve closes and the balloon inflates, producing a second pulse of flow during diastole. So diastole continues through here. Just before systole, the balloon deflates, opening up space in the aorta and actually sucking blood into that space, producing reverse flow. Then the normal ejection, balloon inflation with a second pulse, balloon deflation, and so on. Here's an example of a patient, mid-right common carotid artery with an intra-aortic balloon pump running at a 1-to-1 ratio. And again, you can see the balloon inflation here, deflation, normal ejection, balloon inflation, deflation through the cardiac cycle. Naturally, this can produce some problems if you're trying to figure out if the patient has a significant carotid stenosis. Many patients with intra-aortic balloon pumps have those pumps because they have cardiogenic shock from a myocardial infarction and maybe getting ready for a coronary revascularization of one type or another, or perhaps they have severe heart failure, and you'd like to know if they have concomitant carotid disease. This example here shows a 1-to-1 cycling intra-aortic balloon pump with pretty variable peak velocities. The one that was measured here is 229, but even the lowest ones over here, about 160. So this patient probably has a lesion in this area here. It's probably not a critical one, but probably greater than 50%. A good way to find out about the reality of some of the flow abnormalities and the velocities that you see with the intra-aortic balloon pump is to turn the pump off. This is an illustration of that. Here's the pump pumping along, and then in the middle of the panel, the pump was turned off for a couple of cycles, and you can see the flow pattern is a normal carotid flow pattern. This is the internal carotid artery, and the peak velocities are normal. In this case, they're normal both with the pump on and off. Obviously, if the patient is heavily dependent upon the pump, you want to interrupt the cycling for as short a period as possible. I mentioned left ventricular assist devices, and obviously these are not in common practice everywhere in the world, but it is useful to know a little bit about them. Generally, they're used in patients who have intractable heart failure, and they're typically a bridge to transplantation. The current pumps, most recent generation, and I'm sure there'll be additional technical refinements as we go forward, but these pumps are generally valveless. They typically have continuous flow using a magnetic impeller. They try not to have any mechanical things. And the flow, or I should say the impact of a left ventricular assist device on peripheral flow really depends on the nature of the device itself. Is it a pulsatile flow or more commonly continuous flow? And what about the natural heart function? So what you see in the peripheral flow patterns is a combination of the pumping, continuous or pulsatile of the LVAD, plus whatever it is the heart may be doing to contribute as well. So here's an example of an internal carotid flow pattern in a patient who's on a left ventricular assist device. And take my word for it, this patient's sitting in bed conversing, feeling just fine with a continuous flow of in his left and right and both vertebral arteries with peak velocities in the 10 to 12 centimeter per second range. But this is the kind of thing you would see in that setting. The last thing I want to mention is arrhythmia, and of course there's different types of arrhythmias. Atrial fibrillation is a common one. The impact of atrial fibrillation is both an irregular heartbeat and also the loss of the atrial pumping function for filling the left ventricle. So you'll have variable ejection based on the irregular heartbeat and also irregular ventricular filling. Here's a typical kind of example you may see in a patient with a cardiac arrhythmia. And the question always comes up, there's a number of different velocities here, depending on which one of these bumps you pick. How do you know which one is the one that's really representative of the flow when you're trying to use a criterion to determine a significant stenosis? And in this particular case, I think you want to try to avoid the ejection that happens after a long delay. This is a situation where generally ventricular filling is good or better than usual. And you want to avoid ones when the interval between the pulses or the pulse period is relatively short, because there's going to be a small ejection here because of lower filling of the ventricle. Probably the one selected by the sonographer here is the best one. In this particular case, all of the peak velocities are normal. Of course, we're looking at the common carotid artery, but this kind of problem can come up again in patients with concomitant carotid atherosclerosis and coronary heart disease. So you have to be careful of selecting the right cycle for your measurements of velocities and determination of stenosis. So in conclusion, a lot of different conditions of the heart and some of the aorta can have a big impact on what we see in vascular studies through the body, but particularly prominent effects in the carotid arteries and the vertebral arteries due to their close proximity to the heart and the greater impact of changes in cardiac function and aortic function on those particular vessels. Understanding the clinical situation of the patient and the hemodynamic status at the time of the examination are really important in being able to sort out how these potentially central issues can interact with disease in the carotid or vertebral arteries themselves. The key to identifying the cardiac cause of flow abnormalities that we see is that symmetry. And depending on the type of unit you have where you're doing carotid diagnosis, physician sonographers, non-physician sonographers, and so on. The most important thing, like always, is communication among the vascular team to come up with the best diagnosis for your patient. So thank you very much. That concludes my presentation.
Very good. Thank you so much, Michael. It was a wonderful presentation with a lot of information, very useful for all people that perform the sonogram and for those that must to make the interpretation of the sonogram. So do you have any additional comment or something?
Not really. I think that our two talks really complemented one another. I think you went over a lot of the important aspects of making the diagnosis of significant carotid atherosclerosis in the standard examination of the neck, and looking at some of the fine points that you might see in patients with other conditions.
Yes.
I think really completes the picture of how a comprehensive cerebrovascular ultrasound examination should be considered.
Absolutely. Well, I must say that I'm very happy with our webinar. The WAFUN maintains its constant position or dedication for education, and I think that this kind of program with a very outreach by using the internet is an extraordinary tool to share knowledge and to share experiences. So thank you all. Thank you, Michael, first for your contribution to this webinar. Thank you so much for joining us. And I want to thank all the audience for watching, for joining, and we will see you in another webinar organized by the WAFUN. Thank you so much.